Good afternoon and welcome. I'm Dr. Carrie Bernard, President of the College of Family Physicians of Canada. I've spent the past 25 years working in the city of Brampton at the Queen Square Family Health Team and William Osler Health System Hospital. I am extremely excited to be here today, engaging actively in our democratic process. So thank you for taking the time to join us for this important national conversation about one of the most urgent healthcare issues in Canada today, ensuring that every Canadian has access to a family doctor. First and foremost, thank you to our speakers for making yourselves available as we take time to learn about your party's priorities and commitments in this important area. We know that family physicians make a critical contribution to the health of their patients. Having a family doctor is associated with better health outcomes, fewer trips to the emergency room, and extended life expectancy. Unfortunately, right now, more than 6 million Canadians are without a family physician. These are our family members, neighbors, and friends, people living with chronic illness, caring for loved ones, or struggling with their mental health, without the consistent, trusted support of their family doctor. Family medicine is the cornerstone of our healthcare system, and today we're putting the spotlight on this critical issue as we head into this federal election. As you listen to today's discussion, we encourage you to reflect on the key priorities identified by the CFPC based on what our 47,000 members tell us. Number one, we need to see better investments in family medicine. Canada needs more family doctors. That means increasing our training spaces, offering fair compensation, expanding loan forgiveness, and accelerating recognition for internationally educated physicians. Number two, we need to reduce the overwhelming administrative burden that we as family doctors face. We currently spend 10 to 19 hours per week on administrative work. At least some of this time would be better spent directly caring for our patients. We need immediate federal action to eliminate low-value administrative tasks, such as paperwork and requirements for federal forms with sick notes. Number three, we need to support family doctors with team-based care. Canadians deserve care delivered by collaborative interprofessional teams featuring the clinical leadership of family physicians outlined in our Patients' Medical Home Vision. Federal investments are needed to expand and standardize team-based care across the country. These solutions are not only feasible, they are essential. Now, today we are joined by representatives from three major federal parties. Each has been invited to answer this key question. With more than 6 million Canadians lacking access to a family doctor, how will your party ensure access for all? Each representative will have 5 minutes to respond. After the opening statements, we'll move into a short rebuttal and discussion period, followed by questions and answers submitted live by you, our CFPC members. If you're watching today and would like to submit a question, please do so through the live stream chat. Our staff will select the most pertinent questions. We kindly ask that questions remain respectful and focused on healthcare priorities being discussed today. I'm now pleased to introduce our three representatives. We have Dr. Stephen Ellis, representing the Conservative Party of Canada, running in Cumberland, Colchester, Nova Scotia, who served as Shadow Minister of Health in the previous Parliament. We have Dr. Doug Eyolfson, representing the Liberal Party of Canada, running in Winnipeg West, who served as Liberal MP from 2015 to 2019. And we have Mr. Peter Julian, representing the New Democratic Party of Canada, running in New Westminster, Burnaby, British Columbia, who served as health critic and who served as health critic in the previous Parliament. So we're going to begin opening statements in alphabetical order by last name. Each participant is going to have up to 5 minutes to respond to our main question, and I will give a reminder when your time is coming to an end. Again, with more than 6 million Canadians lacking access to a family doctor, how will your party ensure access for all? First, we'll hear from Dr. Stephen Ellis, Conservative Party of Canada.
Well, thank you very much, Dr. Bernard. It's a pleasure to be here today. And I did have the opportunity to be trained here in Canada. I think it's been a lovely opportunity, obviously, and practiced family medicine until I was elected in 2021. I did have the opportunity to serve in the Canadian military as well. So this has certainly been the mission that I have undertaken over the last 2 years to understand how we can improve access to healthcare. And first and foremost, we do know that national licensure is incredibly important. We hear that from physicians over and over, and I'm proud to say that here in the Atlantic provinces, that dream has come to fruition. The second part that's incredibly important is how we license and test the competency of international medical graduates here in this country who have experience and training elsewhere. We do have had haphazardly applied practice ready assessment program across the country to assess competency, and certainly pairing internationally trained physicians with Canadians makes really good sense. That needs to be paired with a CARM style match as well, because otherwise all we're going to have is provinces and cities bidding against each other, which is what we see now. Thirdly, we need to look at repatriating Canadians who have studied abroad. As many of you know, certainly many Canadians have taken the opportunity to train in places like Ireland and the Caribbean. They need a place to land when they come back to Canada. Of course, they do have competency in our language and culture already, so finishing their professional training here would make the most sense. Uh, the final thing, which becomes perhaps somewhat controversial in front of the College of Family Physicians, is we need to look very carefully at the training time burden that exists with respect to how long it takes to become a family physician. Why do I bring this up? Because as I went, I had the opportunity to go across the country and talk to many stakeholders, whether they be medical regulatory authorities or national bodies such as the college. It is incredibly important to understand that we are in a crisis here. And if we don't show significant leadership from anyone who is a stakeholder inside the system itself, then we know that the status quo will continue. And I certainly believe that there are opportunities in some programs now to look at the training time burden, and also to understand, and again, perhaps somewhat controversially, and I'm happy to hear your comments about it. But is it important for certain family physicians, for instance, to have a family medicine research type of project if they have no interest in providing research? Do they need to be competent in understanding research? Of course they do. But that being said, if they don't really have any interest in research and want to start seeing patients, perhaps there's efficiencies to be found there. And of course, looking very closely at the curriculum and understanding certain programs would still have 17 weeks of time between first and second and third year. And I think there's opportunities for change there. And I have taken that opportunity to speak to deans of the 17 medical schools currently, and to help them understand that that is finding those efficiencies inside the time of crisis is going to be incredibly important. I don't want to understate for a second the important work that family physicians do and the range of opportunities from providing office-based care and teams, as Dr. Bernard mentioned, but other opportunities, of course, in the emergency room, providing inpatient care, mental health care, addictions, all of those important avenues that are covered by family doctors. But as I said previously, we know very clearly that we are in a crisis here. And for Canadians who do not have access to the system doesn't work for them at all. They are left scrambling to find care in ways that they become very creative and adept at finding. And at the doorsteps, having knocked on over 3,000 doors in this since the writ has been dropped, then we know that people are feeling the pinch, that they are very anxious about how they're going to obtain care going forward. And as I said previously, those of us who are stakeholders inside the system, when we have a crisis at hand, that we have a significant responsibility to Canadians to provide this service, and for all of us to be rowing that proverbial boat in the same direction and understanding how we're going to get there. I look forward to your comments. Thank you for your time.
Thank you very much, Dr. Ellis, and thank you for keeping exactly to your time. I'm going to move on now. We're going to hear from Dr. Eyolfson from the Liberal Party of Canada.
Well, thank you, and thank you for this opportunity to speak in the public forum. I am by training an emergency physician. I have a Royal College Fellowship in Emergency Physician in 1998. Since then, I've worked a number of emergency departments and primary care clinics across Winnipeg. I've also flown with our provincial air ambulance system called Lifelight for 13 years, and spent many occasions going to northern and remote areas to medevac patients back to Winnipeg for more advanced care. As you say, I served as a member of Parliament from 2015 to 19, and then recertified to practice emergency medicine, and have been working as an emergency physician since. While also spending some time in the intensive care unit. Working in emergency gives a perspective as to what kind of problems there are in the medical system, as well as in the social safety net in general. I agree with Dr. Ellis in that the lack of family physicians is a tremendous problem. There are patients who either don't have family physicians or cannot arrange to see them in a timely manner. Their problems get worse. They come to the emergency department. If they had been able to see a primary care physician earlier in the course of an illness or a problem, it may have been a minor problem. By the time they get to see us, things have often gotten much worse, and this does make illness worse, can occasionally increase mortality. The emergency department has for years been called the canary in the coal mine of our healthcare system. And there are many deficiencies in the system that we see firsthand. So we do need to solve this problem of not enough primary care providers in Canada. We do have to work collaboratively with the provinces, because as we know, healthcare is a provincial responsibility, and it is funded by the federal government. I know from my experience in Parliament, trying to simply tell any province what to do is met with opposition because, as they insist, it is a provincial responsibility. So we cannot dictate, but what we can do is make sure that we have targeted funding for the different programs that they need. We do need many more family doctors. We need to increase the training spots available for family doctors. We need to work collaboratively with the provinces to make sure that these are funded. If they do not have enough funding for that, we need to make sure they have it. And we have to make sure that it is, in fact, targeted funding. To give this funding to the provinces, saying, you will use this to increase training spots for family doctors. You will use this to make sure that we have more family doctors in our system to look after Canadians. If any administrative burdens that are under federal jurisdiction, again, we want to change. The burden of paperwork, I agree, is quite arduous for family physicians. They could be much better spent doing patient care, and some of that needs to be tightened up. There needs to be systems in place that relieve that burden. Mention was made of sick notes for going to work. That needs to be abolished Canada-wide. In emergency, I've seen patients come in for no other reason than they had a very bad cold, didn't go to work, and then they have to come and wait 12 hours in the emergency department to get a sick note from us saying they were sick. And this shouldn't continue. So we do want to make this a priority to fund the provinces and make sure that the funding is used properly for increasing the number of primary care practitioners in Canada. Thank you.
Thank you so much, Dr. Eyolfson. And again, thanks to all of our candidates for respecting the time of their other other speakers. So, Mr. Julian, what do you have to say from the NDP?
Thank you very much. I'd like to thank the College of Family Physicians of Canada for sponsoring this debate. And I would like to acknowledge that I'm speaking to you from the traditional unceded territory of the Kakite First Nation and the Hokomena-speaking Coast Salish peoples. We are in a crisis with a shortage of family physicians. And what I want to do in the next couple of minutes is outline the NDP's response to that crisis and some of the other initiatives that we have put into place in this last parliament that help to relieve the pressure on family physicians that do a remarkable job right across this country. The NDP is the healthcare party. Tommy Douglas, former NDP leader, was the one who brokered the agreement in a minority parliament 60 years ago that actually led to our universal healthcare system. And so we believe in meeting this crisis head on by doing a number of things. First off, both under Conservative and Liberal governments, we've seen a reduction in healthcare transfers. We want to increase the healthcare transfers to the provinces, but also work with the provinces at the same time to relieve that pressure of family physicians. And you may have heard Jagmeet Singh's announcement just a few days ago, where we talked about in meeting that bold goal by 2030 of having a family physician for every family in this country. What that would require and what the NDP plan sets out, in addition to increasing the transfers, is to ensure that we're funding 1,000 additional residency positions, that we're streamlining the process for American doctors, many of whom in the current political environment in the United States no longer want to practice in the US, ensuring as well that we're relieving the administrative burden. And that includes working with the provinces for pan-Canadian licenses. So Canadian doctors don't have to go through a very convoluted and complicated process when they want to practice in another province, particularly in border areas. This makes a huge difference. Now, what the NDP has also done in the last parliament to relieve the pressure on family physicians was pushed hard for the new dental care program. And I know family physicians that have had patients that have come in with dental emergencies because they simply couldn't afford to go to a dentist or a denturologist or a dental hygienist. The NDP pressure on the dental care to put the dental care program into place has already helped 2 million Canadians that have had over the course of the last year services from a dentist. And at the same time, with the expansion at the end of next month, up to 10 million Canadians will be able to benefit. At the same time, our push for pharmacare is vital. And as you're aware, Canadian Federation of Nurses Union speaks very clearly to this. We lose about 650 Canadians every year because they can't afford to pay for the medication that their family physician has prescribed. The first step of that pharmacare program is on diabetes medication and devices. That will save lives. But we have a reporting back mechanism that was included in the pharmacare bill as of October of this year. We will be hearing back on formulary, on the bulk purchasing strategy, and the expert committee that actually traces the route forward on pharmacare. We need to roll that out, and the NDP is very adamant about that. The other two political leaders seem less warm to the idea that we bring in universal pharmacare. We want to make sure that that becomes a reality. Now, I want to come back to the administrative burden. Family physicians have to fill out disability tax credit forms, even when their patient has already qualified at the provincial level. To streamline paperwork for family physicians, it includes finding other ways of having people move on to the DTC, ensuring that we actually make it a streamlined process for administrative burdens. And I'll give you a key example of dental care. When the Liberals rolled out dental care, because the NDP pushed them on it, the original formula was too complicated for dentists to sign on. And so I sat down with the Minister of Health, and he agreed to what the NDP proposed in terms of streamlining the dental care application process. And today, as I mentioned, it is a roaring success, and about 95% of Canadian dentists are involved. So the NDP is standing with family physicians. We want to meet that goal of 2030. and we want to relieve the administrative burden, and you can count on NDP MPs to speak up in the House of Commons for all of those things.
Thank you, Mr. Julian, and thank you to all of our candidates for your opening remarks. I heard an awful lot about reduction in burden, issues relating to training, adjustments that need to happen in relationships with provinces, and some about how challenging that can be when we need to work federally and provincially to address some changes. We're going to save a lot of our time for questions from the audience, but I'm now going to open the floor for 3 minutes in case any candidate felt rushed and wanted to add a clarification, or if something one of the other candidates spoke about made you want to clarify. I'm not going to go in the same order, but I'm not going to go in reverse order because Mr. Julian just finished speaking. So I'm going to ask Dr. Eyolfson if you wanted to add anything to the comments that you made, if you wanted to say anything back to your opponents in what they shared, and I will give you about 3 minutes for that.
Thank you. Thank you. And I'd like to expand on what Mr. Julian said. By the way, it's good to see you again, Peter. I hope to work with you again. In regards to pharmacare and dental care, yes, I do acknowledge the instrumental work the NDP helped in bringing this about. In my term as an MP, I worked on the Standing Committee of Health, and we wrote the first report that was the blueprint for a pharmacare system in Canada. And I'm glad to see that we have the first stages of that. And, I agree with Mr. Julian that it can be, there can be life-threatening consequences of not being able to afford your medication, including, particularly insulin. We know that not taking your insulin because you can't afford it can be fatal. The Liberal Party is committed to maintaining pharmacare and to expanding it beyond what we have now in diabetes medications and women's health medications.
Thank you so much for those clarifications. How about we move on to Dr. Ellis? I don't know if you had any comments to add about pharmacare or anything else you wanted to share with the participants.
Sure, I think there's a couple of things. One of the things that was not mentioned in terms of reducing administrative burden is the use of artificial intelligence. And obviously, that's not going to work in every clinic for everybody, but I think that moving in that direction makes incredibly good sense. The good folks that I've had the opportunity to speak with across this great country are really understanding now that it would be very easy to have systems that automatically transcribe even multiple speakers inside an office. So that transcription burden obviously would be significant. The ongoing use of AI to support things like differential diagnosis, suggested tests and referrals and things like that is going to be incredibly important as we move forward. And as we move towards a population that is more well versed in the use of computerized technology, providing physicians beforehand and integrating their symptoms and signs into a electronic medical record is going to be increasingly important. We also know that there are significant numbers of Canadian companies already who are able to integrate multiple platforms, electronic health records, which again is a cause for wasteful spending inside the system, of course, by replication of tests. The final thing that I would bring forward is both my colleagues have spoken about pharmacare, which I know that Mr. Julian won't like it, but of course it doesn't exist at the current time. The negotiations that have happened with 3 provinces, that being PEI, Manitoba, and BC, represent only 20% of the population, but has already spent more than 60% of the proposed $1.5 billion budget. We know that the gap is about 1.8% of Canadians who are undercovered, and we know that there are better ways, such as supporting provinces like Nova Scotia that has access to their provincial pharmacare for anyone. So I think that underscoring the fact that we need to be fiscally responsible in this very difficult time when we have a debt service charge of $1 billion a week, looking at all of those options is going to be incredibly important. That doesn't mean to negate the fact that insulin and other medications can be incredibly expensive. There just may be other options on how to look at that more closely, as opposed to spending money, sadly, that our country doesn't have. Thanks very much.
Thank you very much, Dr. Ellis. And we'll wrap this section up with Mr. Julian.
Well, thank you very much. And I both agree and disagree with my colleague, Dr. Ellis. I agree with him certainly on health records. That is something I think all parties agree on in the House of Commons, that we need to be able to provide the best possible level of care, and ensuring that that people that physicians are fully aware of the patient's condition is a key part of that. I would disagree with him on his characterization of pharmacare, and every single study that has been done of pharmacare and other countries bringing pharmacare into place has shown that we actually save money as a society. In New Zealand, in some categories of drugs, there was a 90% reduction because of the bulk purchasing strategy that came with universal pharmacare. So the pharmacare fact that passed through the House of Commons and the Senate, that it is now very live, is very important. And the British Columbia Agreement, as with Manitoba and Prince Edward Island, will make a big difference in the lives of the people in those provinces. We saw with universal healthcare, conservative provinces were very reluctant to sign on initially. It took about 3 years before all the provinces signed on to universal healthcare. What happened was that the people, the citizens of those provinces said, we want universal health care, and either, particularly in conservative provinces, either the government changed its mind and signed on, or the people of that province changed their government. And so I think it is vitally important that we move forward on pharmacare. It will save lives. It will actually lessen the pressure on family physicians, and add to a better quality of working life for our physicians. As far as Mr. Carney seems to hesitate on moving forward with pharmacare, I think the Liberal Party needs to be unambiguous that they are willing to put into place the recommendations that the expert committee will be bringing forward by October 14th, as well as move forward on the issue of the formulary and the bulk purchasing strategy. These are all contained in the legislation, and I would hope that the Liberal Party would confirm that they want to move forward. New Democrats will, and we will in the next Parliament use every lever we can to make sure that universal pharmacare becomes a reality, because it's in the interests of family physicians, in the interests of their patients, and in the interests of all Canadians.
Thank you very much for that most unambiguous answer, Mr. Julian. I appreciate it. So I want to thank all of our speakers for their opening statements and additional statements. We're here mostly today to hear from our members of the CFPC to know what they would like to ask of you, and that's why we appreciate your coming. I'm going to choose some of the questions from our audience members, and I'm just going to ask each participant, if you want to go first, just sort of raise your hand if you're excited to go first, or speak up, and then we'll certainly make time for others to weigh in. The first question that we have from one of our guests is the following. There are concerns that family medicine is becoming less sustainable and appealing. What would your party do to make family medicine a more desirable career choice to attract more family physicians? Any ideas? Oh, Dr. Ellis, and then we'll go to Dr. Julian. Sorry, Mr. Julian.
Peter, I knew you would like that one. Thanks very much.
I did.
Yeah. I knew you would. I think choosing to be a family physician really is a vocation. It's almost a calling, as it were. And the difficulty with that, of course, is the tremendous and significant burden that comes with that, of working, 60 and 70 hours a week and trying to spread yourself too thin. That becomes a difficulty, not just with the individual, of course, but with their families. I think that it is incredibly important, as was mentioned off the top, that we do look at family healthcare team-based approaches to care. I have my eldest daughter, who was a paramedic, has gone back to become a physician's assistant. So I think, and certainly having been a physician in the military, that team-based care is incredibly important and valuable because of the ability to be physicians extenders in many cases. And I realize the audience I have, but sometimes they become physician replacements. We have heard from Canadians that those who have nurse practitioners providing their primary care are incredibly happy with that. So having a significant and ongoing wholesale change of how care is delivered in this country is going to be incredibly important. But I can't underscore enough the need to have more family physicians here providing care, because that ongoing burden of providing more and more care and taking more and more of your time is going to continue until we replace the family physicians who have left, and of course have an ongoing supply as we go forward. And looking at that most difficult mathematical equation of saying that we are going to be able to educate ourselves out of this problem at the current time with a lack of preceptors and the, dare I say, lousy pay for preceptors, it's going to be incredibly hard to do that without assessing the competency as outlined off the top of international medical graduates. The other thing is that we, because of the word I use, crisis, it's incredibly important that we use the resources that we have as a federal government, but that we also show good leadership, that all provinces begin to adopt similar ways of, again, of training, of assessment, of competency, of new family physicians who are trained elsewhere, and also the use of family health teams. I think that that's going to be incredibly important, that we have all of the provinces and territories creating very similar models and not competing against each other. And that's going to take significant federal leadership, which we have not seen in the last decade from the Liberal Party. And we need that to be different on behalf of Canadians. Thank you.
Thank you, Dr. Ellis. And I saw you, Mr. Julian, with your hand raised as well.
Yes, thank you very much. The reality is we need to relieve some of the pressure on family physicians. The part of how we do that is to ensure that there are more family physicians, so that we actually have a better distribution of the workload. And that's why Jagmeet Singh's call for 2030 family physician for every family, streamlining the process of American physicians coming to Canada, ensuring that we create another 1,000 residency spaces, and also work on that process to recognize foreign credentials beyond the United States. These are all key elements in relieving and distributing a better workload. It's also family physicians having to treat dental emergencies or patients that simply can't afford medication. These are key components to building a better quality of working life. And that's why the NDP has pushed so hard on things like dental care and pharmacare. But it's also relieving the administrative burden. And the example of the disability tax credit, I think, is something that I want to zero in on for just a moment, because family physicians are involved in the process of an evaluation form that comes for the DTC. Every year, I have a couple hundred people that come out to my town hall on the disability tax credit, because it can make a big difference in the lives of the quality of a person with disability. But it's then the burden is then put on family physicians to fill out those forms. And it's not just the DTC. There are many other examples that we can point to where there's an administrative burden, which diminishes the quality of working life, and means that if a family physician is spending all of their time seeing their patients, that administrative burden is added on to their working time over the course of the week. If we believe family physicians are the front line of our healthcare system, and we believe our healthcare system is absolutely fundamental to the quality and well-being of Canadians, then we need to make sure that those frontline workers, the family physicians, are given the best possible quality of working life and the best possible working conditions. And these are all within the purview of the federal government working with the provinces. The NDP is committed to making that quality of working life better. And I think we have a proven track record of doing so on things like dental care and the first phase of pharmacare.
Thank you, Mr. Julian. And Dr. Eyolfson, what would the Liberal Party do to make family medicine a more desirable career choice?
Much of what has been said by my colleagues is true. I think to help relieve some of the administrative burden, we need to be looking at, what is being done federally. The disability tax credit form is a good example and an opportunity to do that. We will explore what, again, federal barriers, paperwork barriers exist, and do what we can to streamline them. To make this better as well requires cooperation of the provinces. In the 2015 budget, our government, including with the health transfers, we had additional health transfers for home care and mental health, which were, as we knew, underfunded aspects of the healthcare system in many provinces. We had significant pushback from a number of provincial governments who insisted that the federal government had no right to tell provincial governments how to spend their money. And in fact, Manitoba, under Premier Brian Pallister, missed out on $250 million on funding because for 2 years, he refused to sign the accord because he did not want any targeted funding. So we need to work with the provinces and say, do you need funding to assist with these things? We do need more family doctor training spots. And those need to be funded. And if the federal government is stepping forward to help fund that, we need an agreement that the provinces are going to use that. And the provinces are going to have to step forward with some of their own revenue as well. We had a provincial government, our previous provincial government, that was cutting their taxes by $1.7 billion a year, and then claiming they had to close 3 emergency departments in Winnipeg because they didn't have enough cash. And then blamed the federal government for not giving them enough money. We need to take a stronger stance. And I don't mean be dictatorial, but to insist that provinces and the federal government need to work together to increase the training spots and increase the fees that they can bill for. Family doctors have been very angry that their fees have not kept up with the rate of inflation. And as our provincial governments point out very often, this is a provincial responsibility, and they resist being told by the what to do. To work with them to explain we're in this together and we need to cooperate. And increasing family medicine spots and increasing the fees that we're paying family doctors would be welcome steps, and the federal government would assist in that.
Thank you very much for that answer. And it actually ties very nicely into the next question that we've received from a participant. So being mindful of how challenging it can be to work with provinces who are the ones who enact healthcare for all of us in Canada, what would your party do to ensure national licensure for physicians to increase workforce mobility? How would your party go about managing this issue? Who would like to take that on? Dr. Ellis?
Yeah, thanks very much, Dr. Bernard. And this is something I've worked hard on the last couple of years, is meeting with many of the medical regulatory authorities across this country and with the Federation of Medical Regulatory Authorities as well. I think, once again, I'll go back to the statement that I had previously, that this is about leadership, and it's something that's been accomplished here in Atlantic Canada already amongst the 4 provinces. And when you have strong federal leadership to say to provinces, you know what, this makes good sense. There's already a model out there, and adopting this model is the way forward for Canada, is how we're going to move forward with respect to this particular issue. You know, we know that when you are a Canadian medical graduate, when you finish medical school and your residency training, that your ability to get a license in any province of your choosing is pretty much guaranteed. But to have, as you progress through your career, that opportunity to practice somewhere else and have an overly burdensome time to submit all those documents that are required, et cetera, doesn't really make any sense. I do also, though, believe, and I have to, because I've met with many of the provincial ministers already, I do have to take my hat off to the provinces to say that certainly they have worked very hard at attempting to reduce the amount of time it takes to get a license elsewhere, and attempt to reduce the financial burden associated with it, because they know that the crisis that we are in. Um, I did hear one of my colleagues suggest that they would increase the pay for family physicians. I guess I'm curious as to how that might happen. It is a significant provincial responsibility, and there are different fee codes and barriers to doing that across the country. I'm certainly not opposed to it. I'm just curious as to how that might happen, given the jurisdictional issues and the different pays and fee code structures, et cetera, that exists. Thank you.
Thanks very much for that comment. I think that question was for you, Dr. Eyolfson, specifically in terms of discussing increasing fees. So I don't know if you would like to share both how your party would approach national licensure and what type of strategies you think could be employed to help increase the salaries of family physicians.
Certainly, and I agree with much of what Dr. Ellis says. And I, do congratulate those Atlantic provinces that have managed to do this, and we do need this across Canada. Federal governments have been trying for years, if not decades, to achieve this, and have not been able to get agreement among all provinces. And many provinces have stood firm, saying, we will not agree to a national system. Again, we need to be able to regulate this ourselves. And they do. The Canada Health Act says that the administration is of the provinces. But we need to, as Dr. Ellis says, show leadership in, explaining to the provinces and working with them to say, what do you need to increase their fees? And how can we help? And forgive me, the second part of it, there's the other point as well from Dr. Ellis.
The question that I had was specifically related to fee codes and that kind of stuff. But I think
Yes.
Dr. Bernard, I think she covered that.
Yeah, thank you. Yeah, exactly. So that has to be negotiated with the provinces, and we need, significant buy-in with the fee codes, and with the same thing with the fee codes and with the national licensure. We have to, be strong in leadership and say, this is good for you. This is good for your provinces. And what do you need from the federal government to help make this happen? I've had to work. I have done work in other provinces. I held a Manitoba and Ontario license, and getting the Ontario license had to jump through a duplicate of all the administrative hoops that I had to do to get a license in Manitoba. I also found that I could not pause that license when I was no longer doing that work in Ontario. I had to outright cancel it. And if I want to do work in Ontario, I would have to go through all of these things again. That's not acceptable. So we need to, find out from the provinces, what are the barriers? What are your concerns with this? And how can we help overcome those? I'm sorry, Dr. Bernard, I can't hear you.
I could hear myself, so I was muted. I thank you so much for letting me know. I'm going to turn this over now to Mr. Julian to address both of those issues if desired, and both how we would pay and about the licensure.
Well, first off, for the national license, that is something that Jagmeet Singh specifically referred to in his press conference a few days ago, announcing the NDP platform on what NDP MPs will be fighting for in the next parliament to ensure that we can get to that goal by 2030 of having a family physician for every family in the country. And so this is a key component. The NDP MPs will be pushing for that. But at the same time, it really comes from the federal government's ability to start to increase the healthcare transfer. This is something that historically was much higher. It has decreased over the last 15 to 20 years dramatically. And the reality is it is an important carrot for the provinces. I don't disagree with the issue of provinces perhaps being reluctant on this. And I'll come back to that specific example that Dr. Eyolfson mentioned in a moment. But the reality is, with the federal government starting to show its responsibility and stepping up on increasing healthcare funding, these are the kinds of things I think that would be relatively easy to resolve at the provincial table, so that physicians can practice elsewhere in Canada or in border regions, practice on both sides of the border, whether we're talking about Lloydminster or the National Capital Region. That's where physicians are going back and forth across provincial boundaries on often a daily basis. Now, coming back to the example of the Manitoba government that rejected having additional funding and rejected those conditions, I agree that that is something that can happen. I would suggest, though, that that is only a short-term opposition. And I give the example of the fact that the Palliser government is no longer in power in Manitoba. And so the reality is, when there are governments that are pushing, are rejecting federal funding because they're pushing back on what are good, logical ideas in repairing and making better our healthcare system. My sense is that opposition will only be short term, because the Canadians value our universal healthcare system. Support is over 80% according to all the polls. And so Canadians right across this country value our healthcare system. Initiatives taken by the federal government and leadership taken working with the provinces, particularly when it comes with additional healthcare funding, ultimately, I think, will succeed right across the country.
Thank you, Mr. Julian. I'm hearing wide agreement in the room about making this a priority from all parties. I'm going to move on to the next question, which gets a bit more nuanced about this, because while we can all agree in principle, what really matters is when the rubber hits the road. What are we going to do? So the question is, we need a multitude of solutions: increase the number of training spots, open more interdisciplinary training programs, properly resource all the programs to integrate AI and allied health, remunerate family medicine appropriately. What will your government do in the first 90 days to meaningfully advance these? So given the opportunity, what would your government do first? Mr. Julian.
Well, I'll start off by saying in the first 90 days, if there's an NDP government, we will be moving rapidly to address the toxic drug crisis, the mental health and addiction crisis, the affordable housing crisis. All of them have a huge impact on the healthcare system. So these are things that we would move forward on an emergency basis. We've already said, in terms of toxic drugs, declaring a state of healthcare emergency to devote federal resources to that. We are short of mental health and addiction treatment right across the country. Some provinces are doing a very good job. British Columbia is a notable example, but the reality is we need more supports in that area as well. And the fact that there are hundreds of thousands of Canadians that don't have a roof over their head should be a source of shame to all Canadians. So we would move rapidly in those areas. I can say without any hesitation that an NDP budget would include increasing healthcare transfers immediately as quickly as that first budget, and funding those 1,000 additional residency positions immediately as well. So within the 90 days, those things we would be moving rapidly on. There are a number of other really important suggestions that would roll out after that. And I can't give a time frame to it, but the NDP would be treating the emergencies that we have in our country as emergencies and ensuring that there is federal funding to start addressing these emergencies.
Thank you very, very much. Who would like to share next? Oh, I have both. So Dr. Ellis, you've gone last time. So how about you share with us now?
Sure.
Okay,
Thanks
thank
very
you.
much.
Oh, sorry.
Sorry, I wasn't sure who you said. My
I said
apologies.
Dr. Ellis. Yes.
Great. It's tough when our names are so close, isn't it? That being said, I think there's important 90-day goals that need to be met, and for a conservative majority government, it's national licensure. We do believe that the competency-based assessment of international medical graduates, combined with a CARMS-like match, that is work that I've already done behind the scenes over the last 2 years, and that could be accomplished within the first 90 days quite easily. There are several other things that are going to be incredibly important, but given the scarce resources of family physicians to act as preceptors, many of them are perhaps going to take a little more than 90 days. Repatriating Canadians who've studied abroad is going to be somewhat more difficult, but I think there are ways to accomplish that, given things like potentially creating a salary for physicians who are nearly ready to retire and enticing them to become preceptors with a reasonable pay. I think that reducing training time burden is something that I know will be met with resistance perhaps by the CFPC itself and by deans, but I think that looking at those things is going to be incredibly important in this time of crisis. It would be great to be able to tell you that we are going to have more mental health care providers within the first 90 days. Once again, reality must set in and understand that it does take significant amount of time to train mental health care providers, whether they be psychiatrists, psychologists, etc. In terms of addictions and care for folks who are suffering with that very, very difficult time of their life, then I would suggest that there are many opportunities out there already that exist with programs that have proven track records already, and partnering with those programs that already exist is going to be incredibly important, and I'll use the term almost using a franchise-like model to roll that care out for folks who suffer with addictions across the country would be incredibly important. So I do also believe that that is something that could be accomplished within the first 90 days. Bringing U.S. physicians here, sadly, only Nova Scotia and Ontario have reciprocal agreements to accept U.S.-based training, and again, encouraging provinces to roll that out across the country would be very important as well. And I think there's some other trusted partner countries that all of us could imagine who they might be to bring physicians to Canada, and making sure that that happens quickly would be within the first 90 days as well. Thank you.
Thank you, Dr. Ellis. And I'm going to turn now to Dr. Eyolfson.
Thank you. I should say I wanted to respond very quickly to something that Mr. Julian said, and he is right with the opposition that we had from the Manitoba government. Manitobans did speak up and have changed that government. We do have a provincial government that is much more cooperative, and we need to work with the provinces to make sure that we can have agreements and cooperation between the governments. We need to come forward, and I can't say what we'll do in 90 days, but what we will start with is to speak with the provinces and say, what do you need? Engage with them. What do you need? How can we help? We need to make sure that the needs are met and work together in those. The statement on increasing health transfers that Mr. Julian said, we have, as Dr. Ellis said, a fiscal reality. The Canadian government used to fund a much higher proportion of healthcare transfers. In 1980, the federal government funded 80% of healthcare transfers. But in 1980, the top marginal tax rate was 70% for an income of $80,000, which translates to something over $300,000 a year. Are Canadians willing to accept such a drastic increase in taxes? I'm sure they are not. So yes, there's a role for increased funding for increased healthcare transfers, targeted healthcare transfers as well. We need to have more agreement that we can target some of these and say this money goes to that. And if the provinces need more money in training and making for new family doctors, then talk with the federal government. What do you need? We need to work with you. We can't have a relationship where we just write blank checks. We need to make sure this funding is going to where we need it. And Dr. Ellis is correct in his assumption that there will be resistance to decreasing the training time for family doctors. I remember 30 years ago when the internship, the 1-year internship, still existed. At the end of that 1 year, I had a license to practice medicine. I went directly into a residency, but I was licensed to go and hang out my shingle as a GP. Was I actually prepared to work independently as a physician with no oversight? I will say barely. And in 30 intervening years, there has been a tremendous explosion in the amount of medical knowledge. So as much as we have to address a crisis, we cannot address it by potentially jeopardizing public safety by relaxing the training requirements on physicians.
Thank you very much. I suppose one of the elephants in the room that we're all sort of neglecting is when we send money to the provinces, do they actually account for how they spend it when we think it's being used, which is always challenging. So first, where our time is coming to a close, and Mr. Julian, Dr. Ellis, Dr. Eyolfson, and everyone tuning in today, I just want to thank everyone for their attention and also for their participation. Having the ability to participate in our democratic process by asking pointed questions, by feeling free to disagree respectfully in public, and knowing that when I arrive at the ballot box, my vote is counted, is something that I never ever take for granted. And so having an opportunity to engage in this type of discussion is really, really meaningful to me as a Canadian, as a family physician, and to all of us at the CFPC. We've heard many interesting perspectives this afternoon, but one thing came out loud and clear, and that's that access to family doctors is a priority across parties. When I was on the Hill back last fall, I heard this from every single MP that I spoke with. Every single one of them didn't just speak with passion, but they had an individual story to tell about somebody who either had an incredible experience with a family physician or somebody who was really, really sad that they couldn't access one in a timely manner. So I know that this is very important to all of you and to all of your constituents. It resonates all around the country that having access to a family doctor is not a luxury, it's essential. And we've seen encouraging steps through bilateral health funding agreements and between the federal government and provinces and territories, and the focus on health. These agreements have helped direct attention and resources to primary care. But the level of commitment to family medicine, specifically, as you all described, varies between jurisdictions. And many of the targets that are currently in place only extend until 2026. So we feel this really gives us a crucial window of opportunity. So I want to say that we can and must build on this momentum with a sustained national approach, one that supports the growth, stability, and evolution of family medicine across Canada. The College of Family Physicians of Canada will continue to advocate for such solutions because we know that a healthier future for Canada starts with a family doctor for every Canadian. And after meeting with the three of you today, I feel like we're in good company. We're around people who also believe that this is important. So thank you very much for your participation. And I want to thank all of the audience members for their participation as well. And I just want to say merci.
Thank you.